Good evening, everyone. I'm sorry for these technical issues that we have. Hopefully, right now we can proceed well with the webinar. So, well, my name is Alfonso Borona, and I will be moderating today's webinar. And I would like to welcome you all to this online session on ASH Highlights 2016. So, as part of Myeloma Patients Europe educational program, this session has the aim of informing patients, caregivers, and patient advocates and provide them with a review of the most recent myeloma findings that were presented at the annual meeting of the American Society of Hematology that took place in San Diego in December last year. So the talk will be given by Dr. Laurent Garderet from the Department of Hematology of the Sant Antoine Hospital in Paris, France. So, Doctor, on behalf of Myeloma Patients Europe, I would like really to thank you for your kind collaboration and for providing all of our attendees with the latest information that came out from the Congress. So, for your information, this webinar will be fully recorded and uploaded to the Myeloma Patients Europe website, which is www.mpeurope.org. And well, just before we get started, I would like to make a small summary on the webinar dynamics. So as you know, the webinar is scheduled from 12:15 to half past 1. So the presentation will last about 45 to 50 minutes. And then I will open a session for you to ask any question that you might have. So basically there are two ways in which you can make your questions to the doctor. So if you want to make your question using the microphone in your computer, which is something that I strongly recommend you can press the raise hand button icon that you can see on your screen, and I'll unmute you so you can make your questions when it is your turn. The other possibility is to do that in writing in the Q&A window. So I will get those questions and I'll read them to Dr. Garderet. But in any case, I'll encourage you to make your questions using the microphone in order to have a more interactive session. So without further ado, I wish you all a very interesting and fruitful webinar, and I give you the floor, Dr. Garderet.
Yes, hello, good morning. I would like first to know, do you want me to do the presentation first and the questions after, right?
Yeah, that's it. So you can start with the presentation, and once it's finished, I will open the questions. That's it.
Okay. So good morning, everybody. I made a summary of the most important highlights that were presented this December 2016 at the ASH meeting. Of course, we'll only be talking about myeloma and also AL amyloidosis because this year there was a very interesting oral presentation focusing only on AL amyloidosis. So the next slide. So the next slide is about drug combinations and focusing especially on the use of daratumumab, the monoclonal antibody against CD38. And as you are very well aware of, this is a very active drug. This drug actually is as an activity against myeloma by itself in monotherapy, but it is also tested at every stage of myeloma in combination. So the two most presented and advanced studies of daratumumab in combination are the ones in the relapse setting. So you had an update of two ongoing studies and that have already been presented. The so-called Pollux study combining Revlimid plus Dex plus or minus daratumumab, and that was presented by Philippe Moreau from the IFM. And the other one is Castor trial, Velcade, Dex plus or minus daratumumab. Both studies showed outstanding results when you are adding daratumumab to either one of the doublet. The most impressive results are those with Revlimid Dex plus daratumumab. We are expecting a very high median PFS. Actually, the median PFS was not reached when this was presented, but investigators believe the PFS, the median PFS, progression-free survival, will be probably the longest ever reported in the relapse setting. As you may know, today one of the best relapse combination is carfilzomib plus Revlimid plus dexamethasone, and probably this other combination in the near future will be very much used. I'm talking about Revlimid, dexamethasone plus daratumumab, so potentially a new standard of care in the relapse setting. Not only it is very efficacious, but also the toxicity is very low. As you know, this is an IV treatment, and you may experience side effects, usually mild, and mostly only during the first infusion. About 50% of the patients experience some kind of side effects at the first infusion of daratumumab, and these side effects are relatively mild. So daratumumab in combination, either with Revlimid Dex or also with Velcade Dex, showed great promise. Other combinations, also Revlimid based, if I may say, it's adding to Revdex, the doublet, Revlimid Dex, a third drug, and we had two oral presentations, one by Philippe Moreau showing the efficacy of Revlimid Dex plus ixazomib, the new proteasome inhibitor, oral proteasome inhibitor, and in the first line setting, and for transplant eligible patients. This is a 3-drug combination given as an induction treatment, and then as a consolidation with a short and a long consolidation phase, and then a 1-year maintenance phase with ixazomib alone. The results were good, and with a good efficacy and especially an excellent tolerability, and therefore this is a new encouraging drug combination. As you know, this drug combination has already been reported, published in the New England Journal of Medicine in the relapse setting, showing outstanding results. So this one is in the, this study is in the first line, and this is a phase 2 study actually, because the safety is excellent, with very little side effects. Currently, and you may remember, this is an oral drug given on day 1, day 8, and day 15. So 3 pills once a week every 28 days. And the idea that currently is maybe to give it twice a week to have even better results in terms of response, depth of response, and response rate, and we hope without increasing the toxicity. So that is a first three-drug encouraging new combination. The other one is again Revlimid-Dex based plus carfilzomib. As you know, carfilzomib is also a very potent anti-myeloma drug. It has been compared against Velcade-Dex, VD versus carfilzomib-D, and carfilzomib dexamethasone was twice as good as Velcade-Dex, and in the relapse setting, Revlimid-Dex plus or minus carfilzomib has been published in the New England Journal of Medicine in the phase 3 trial with excellent results for the three-drug combination. So here again we're talking now about first-line treatment, and the IFM did a phase 2 study, and that was presented by Muriel Roussel, and the Americans also presented kind of similar study, but with a much longer maintenance phase. To summarize, the efficacy is absolutely outstanding, with a very strong anti-myeloma effect when you are adding carfilzomib to Revlimid-Dex, but some caution about vascular, what we could call vascular toxicity, mostly cardiovascular toxicity, and that was especially reported in the French study. During the Congress, there were also many studies focusing on this potential issue of vascular toxicity with carfilzomib and how to prevent it. But again, a very good three-drug combination. I mentioned also this is not a drug combination, but it's daratumumab given subcutaneously. Currently, it's IV, as I said before, and the first drug is about 6 to 7 hours long, the first infusion, and then you may decrease it to 3 to 4 hours. But now, I mean, very soon we will get the subcut route, and it will take 20 minutes and probably even less. So the preliminary trials showed the same efficacy comparing the two routes, subcut versus IV, and with a very good safety profile. So definitely daratumumab will very soon be part of the myeloma treatment. The other issue is could we use daratumumab and as a retreatment, because it is also approved in the relapse setting in some countries, and therefore new drug combinations are also adding daratumumab, such as pomalidomide, Dex plus daratumumab, and the question is, will it be successful again in a new drug combination as a retreatment? And the preliminary results are encouraging in this regard. I would like also to mention the checkpoint inhibitors. You know that the three main new therapeutic classes in myeloma are the monoclonal antibodies that we just mentioned one of them. The second new class are the checkpoint inhibitors, and the third ones are the CAR T cells, chimeric antigen T cells. So in terms of checkpoint inhibitors, this is also tested in the field of myeloma, with maybe for the time being less outstanding results compared to other cancers, but still pembrolizumab, Keytruda, was tested. This is an anti-PD-1 antibody, and it releases the T cells, the autologous T cells, and in order to have an anti-myeloma effect. So that was combined with pomalidomide dex, and with some interesting results. And as you may know, they observed also some very specific new side effects, and you have to be aware of that. The checkpoint inhibitors have a specific toxicity profile, and especially some autoimmune side effects such as pneumonitis and hypothyroidism. New drugs. So not only I mentioned the monoclonal antibodies, the checkpoint inhibitors and the CAR T cells, but new drugs have also been presented, and three of them are listed on this slide. First, venetoclax. So venetoclax is an anti-BCL2 drug inducing apoptosis, meaning the death of the tumor cells, of the plasma cell, malignant plasma cells. This is a very promising drug, not only in myeloma, but it has also shown some very interesting results in the field of lymphoid malignancies. And especially in myeloma for those who have a translocation 11-14. And why is it so efficacious in this subset of patients? It is because of this. The reason is because of this translocation. There is an increase of BCL2, and BCL2 is pro-tumor. So if you stop BCL2, you induce death of cancer cells, and that's why this drug is so efficacious for this subset of translocation for 11-14 myeloma patients. So very interesting new drug. The second one is called selinexor. This is an oral drug, and it's a different mechanism. It blocks a nuclear transporter, and in blocking in blocking this transporter on the nuclear surface of the cell, it induces also apoptotic death of malignant cells. This drug has been tested in very advanced disease, what we call nowadays quadruple or even quinta refractory, mean patients who got quadruple, we mean they received bortezomib, revlimid, pomalidomide, and carfilzomib. So this is they have already received these 4 drugs, and if they got a monoclonal antibody, mostly daratumumab, this is called Quinta refractory. And so for these patients who already got almost everything that is currently available, well, almost 1 out of 5 patients still got some response. And this is very encouraging, and therefore it has also already been tested in combination, as it is mentioned, selinexor plus bortezomib dex, or selinexor plus carfilzomib dexamethasone. So a great drug, a great new drug with a new mechanism of action. Finally, I would like to mention nelfinavir. So this has been developed by a Swiss group, and they tested a drug that is well known in the field of HIV treatment. It's an HIV protease inhibitor, and they combined it to bortezomib dex, and they showed some really outstanding results, especially for patients who were refractory to bortezomib, meaning the drug nelfinavir was able to make patients sensitive again to bortezomib. So really interesting drug. So now let's move to autologous stem cell transplantation. This is a major issue because we have all these new drugs, and I'm not talking about the very late ones, but lenalidomide, bortezomib, carfilzomib, and we nowadays have good results combining these drugs. It has been questioned if whether we should still do autologous stem cell transplantation, at least for what we call the fit patients. Last year, the IFM presented the results of the so-called IFM 2009/DFCI. This is a combined study with the Americans, and they clearly showed that patients should receive upfront autologous stem cell transplantation and not delayed, not at relapse. And this will soon be published in the New England Journal of Medicine. So that was presented last year, if I'm correct, by Michel et al., and showing strongly that patient fit enough should get in first line after an induction phase an autologous stem cell transplantation. This year we got the results from the European Consortium, EMN, trial in combination with the OVEN group, and Michele Cavo presented major results of this randomized phase 3 study, addressing the issue of upfront autotransplantation versus no upfront transplantation, and single versus double autologous stem cell transplantation. So for the first randomization, single versus chemo, clearly shows that there was a major advantage to receive autologous stem cell transplantation up front. So confirming the results that were already presented last year by the IFM. So this is very important because it means that at least for the time being, patients who are fit enough should get an autologous stem cell transplantation in first line, and that remains the consensus. It may change in the future, but the IFM study plus the EMN studies clearly show a benefit of autologous stem cell transplantation up front. Now the other question was, is, and it's still ongoing, should we do a double tandem, what we call a tandem autologous stem cell transplantation, meaning two auto transplant within 3 to 4 months. So that this is what we call tandem, and upfront in first line. That question was already addressed many years ago, and the IFM showed that there was a benefit only for patients who didn't reach the state of very good, the stage of very good partial remission post first autologous stem cell transplantation. However, since most of the patients do reach that point after the first autologous stem cell transplantation, currently the common practice is not to do a tandem auto transplant because there are very few patients who do not reach this VGPR state after the first transplant. And moreover, not all the clinical studies, randomized trials, did show a benefit in the past of the double versus the single auto transplant. So Michele Cavo presented again this randomized study with this new, the same issue, and he was able to show a benefit for double versus single in terms of progression-free survival. As you can see, 73% at 3 years versus 62%, which is borderline statistically significant. And one important notion is that this was especially beneficial for what we call the high-risk patients. So, and actually there is a trend nowadays for high-risk patients to do double auto transplant instead of single auto transplant. This was also tested by the Americans in the so-called STAMINA trial, and that was presented as a late-breaking abstract. And the question is that there were 3 arms after, so fit patients, upfront first-line treatment. All patients got a first autologous stem cell transplantation, and then you had 3 arms, either VRD consolidation, 4 cycles, or a second tandem auto transplant, or no consolidation. And all patients received maintenance with lenalidomide. And the results were quite disappointing or unexpected. the double transplant in this trial didn't show any benefit. Actually, not only the other arm, VTD or maybe VRD, I think it's VRD consolidation, didn't show also any benefit. So there was no benefit of any consolidation as long probably as long as if all the patients do receive lenalidomide maintenance. So that was quite unexpected. Therefore, it is still uncertain if whether you should patient should get a double transplant or a single. But what is sure is that nowadays single autologous stem cell transplantation is the standard of care. Now we move to a different field. It's the field of kidney failure, kidney impairment. This is a major issue in myeloma, mostly because of the light chain toxicity inducing cast in combination with another protein, and that this is what we call myeloma cast nephropathy. And this is really detrimental if a patient has a kidney failure. The French initiated a trial some years ago comparing two types of dialysis. As you know, sometimes patients need dialysis because of the severity of the kidney failure. And the French tested two kinds of membrane to do the dialysis, the standard one or the so-called high cutoff membrane. And they were able to show, and this was presented by Jean-Paul Fermant, that, and this is important, as you can see, at 3 months, 1/3 of the patients were free of dialysis with the standard membrane versus, so 33% versus 41%, so no 41% with the so-called HCO membrane, the new membrane. So this is not statistically significant, but at 6 months, you move from 35% of patients free of dialysis to 57%, and this is statistically significant. And it's even more convincing at 1 year. At 1 year, you move from 37% to 61% free of dialysis with the new membrane. So almost a little bit less than 2/3 of the patients who needed dialysis at diagnosis when the myeloma was discovered, 61% were free of dialysis at 1 year. So this is really a very important result, and potentially this new membrane, HCO membrane, will become a new standard for patients who are in dialysis because of myeloma cast nephropathy. So very important result. Another retrospective study was presented by my American colleague Mahindra Anuj, and he was able to show that nowadays even if a patient has a kidney impairment, even dialysis, if autologous stem cell transplantation is done, the outcome is similar. Similar meaning between those with and those without kidney impairment. So it shows that again that autologous stem cell transplantation should be performed even though there is any kind of kidney impairment. So important data concerning myeloma and kidney failure. I'm just mentioning the imaging new techniques. You know that we, in order to assess bone lesions, we moved from standard skeletal survey to MRI. MRI is the new standard to evaluate bone lesions. But we also have PET-CT, and PET-CT not only show bone lesions, but also extramedullary lesions such as plasmacytomas. So already last year, the IFM presented the role of PET-CT. That was again Philippe Moreau, and that was the same study, the so-called IMAGEM study, comparing PET-CT versus MRI for newly diagnosed myeloma patients who got autologous stem cell transplantation. Within the IFM 2009 trial, and the two messages were: first, at diagnosis, MRI and PET-CT are similar to evaluate bone lesions, but the other endpoint was before maintenance. PET-CT had a very strong prognostic value, and this was much stronger compared to MRI. So MRI is very good to evaluate bone lesions at diagnosis, but doesn't have the prognostic impact compared to PET-CT. And when before maintenance PET-CT is negative, this is a very prognostic factor in terms of PFS. And actually, as you know, this is now incorporated in the so-called MRD, minimal residual disease definition. They included the imaging with PET-CT. And this year, again, going back to the same trial, the EMN trial, Elena Zamani showed basically very similar results, meaning a very strong prognostic factor if the PET-CT is negative. So this is also another important result. So now we're talking about maintenance. Maintenance is a major issue in myeloma. How long should we treat myeloma patients? This is a very important question, and it is still unanswered. I would like to remind you that so far 3 clinical trials have been published. The one by the IFM, the one by the Americans, and a smaller study by the Italians. And the problem is that the IFM study published in the New England Journal of Medicine of lenalidomide maintenance post-autologous stem cell transplantation versus no maintenance showed a very strong PFS benefit with lenalidomide maintenance, but no overall survival advantage compared to no maintenance. And the PFS benefits is almost 2 years if you get the maintenance. So this is a strong argument for lenalidomide maintenance. The Americans did some kind of similar study. They showed exactly the same benefit in terms of PFS for the maintenance arm with lenalidomide, but they also showed a benefit in overall survival, which is, of course, the real endpoint. And this is of course a very strong argument for lenalidomide maintenance. And to some extent, the Italians showed some similar results. Michel et al. Presented at the ASCO meeting last year, the American Society of Clinical Oncology meeting last year, a meta-analysis combining these 3 studies showing a benefit for the lenalidomide maintenance in terms of PFS, but also overall survival in this meta-analysis. And this year, so I mentioned actually 2 important clinical trials so far that have been reported. The EMN/OVEN trial, the European trial, the STAMINA trial, the American CTN clinical trial network of transplantation American transplanters, and the third one that was presented last year, this 2016 ASH, was the UK trial, the so-called Myeloma 11 trial. And if you're interested, I summarized these 3 trials in another PowerPoint. So in this Myeloma 11 trial, Gareth Morgan reported again the role of lenalidomide maintenance versus no maintenance in both patient populations, those who got autologous stem cell transplantation and those who did not. And he was able to show a strong benefit in terms of PFS if you combine the 2 patient populations. No maintenance, 18 months PFS, and you move to 36 months of progression-free survival, adding lenalidomide maintenance. There was some increase of secondary primary malignancies with the maintenance, and so far no benefit for overall survival. So this trial adds another argument in favor of maintenance treatment, and specifically with lenalidomide. Now, another very important point is the new myeloma assessment. With these new drugs, especially in combination and given before an autologous stem cell transplantation, and in consolidation, and with sometimes some maintenance, we now are able to reach a very deep response with no monoclonal peak detectable, and even immune fixation negativity, and therefore there is this notion that we need now to go deeper and assess deeper myeloma response. So this is what we call nowadays the minimal residual disease, and there are mostly two techniques to evaluate this minimal residual disease in the bone marrow: the flow cytometry and the PCR techniques, the molecular biology techniques. And as I mentioned before, there is also we are also adding the imaging techniques, namely PET-CT. So that was published last year in the Lancet Oncology, and these are and with the clear definition of what is minimal residual disease. So this idea of assessing minimal residual disease has been known for many years in the field of malignant hematology, and is entering the new a new era in myeloma. So one can say that this is the new target. This is what we want to reach, and once you reach this MRD negativity and most important, a sustained MRD negativity, you may think that the relapse will occur very late, and that's why some myeloma investigators believe that in the near future, for the, let's say, standard myeloma patient, myeloma may become a chronic disease and may be cure for a subset of patients. So MRD was assessed in the most two successful trials that I mentioned earlier in the relapse setting. So these patients, I would like to remind you, already had received a lot of treatments. And Hervé Avéloiseau from the IFM used the molecular technique, probably the most sensitive technique, called next generation sequencing, and showed that in the Pollux trial, so comparing Revlimid-Dex plus daratumumab versus no daratumumab, 25% of patients who got Revlimid-Dex plus daratumumab were able to reach this stage of MRD negativity, which again is really the new endpoint. And in the Castor study, so Velcade-Dex, bortezomib dexamethasone plus daratumumab, it was a little bit less, it was 15%. But the important message is, when you compare this three-drug combination with daratumumab compared to the doublet, so Rev-Dex plus Dara versus Rev-Dex, or Velcade-Dex plus Dara versus Velcade-Dex, adding daratumumab, you triple your response rate in terms of MRD. So that brings us back to what we discussed initially. This monoclonal antibody has a very powerful anti-myeloma effect, and in combination, even for patients who already have been heavily treated, 1/4 of the patients can still reach the stage of MRD negativity. So this is, and the fact that again we triple this target with this monoclonal antibody is really outstanding. I would like to finish with AL amyloidosis. And if I'm correct, this was probably the first time that we had a full oral session only on AL amyloidosis, showing clearly that for the first time, we made major improvements to treat this disease. I would like just to remind you to summarize briefly the physiopathology of AL amyloidosis. So you have these malignant plasmocytes in the bone marrow, usually at a relatively low number of plasma cells in the bone marrow, and they secrete a specific light chain that has the capacity to fold and make like something like a foam, the so-called amyloidoses, and this amyloidoses is detected in all the major organs, such as the heart, the kidney, the liver, and also GI tract and neurology. So the origin of the disease is the bone marrow, are the plasma cells, and the secondary product, the light chain, is the one who attack the organs, and especially the heart, which is very detrimental once the heart is damaged. So during this ASH meeting, we got two presentations of this new monoclonal antibody. I must say that this is not the very first one. The PEPIS team in London already reported some very encouraging results with an anti-SAP called anti-SAP antibody, especially with liver response. So this is a new one called NeoD001. And this NeoD001 monoclonal antibody given once a week, once a month, IV, is able, and this is really outstanding, to remove from the organs the light chain deposits, the amyloidoses. And if I'm correct, this is actually the first time that such antibody was able to remove amyloidoses, especially from the heart and also from the kidney, and also it was described some neurologic response. So this is really very promising, and many trials are ongoing to confirm or not these absolutely outstanding results of this new monoclonal antibody. And I should add that there was virtually no side effects, and therefore highly efficacious for the very first time to reach organ response. But not only you have to remove the light chain, the amyloidoses, but you also have to treat the source, the origin of the disease, which is, of course, the plasma cells in the bone marrow. And that this is the the other oral presentation by the Pavia team in Italy. And this is a major international randomized study comparing melphalan, this is an alkylam, a chemotherapy plus steroids, dexamethasone, that has been the standard of treatment for AL amyloidosis for many years. And in a randomized trial, they added bortezomib to this standard treatment. And they were able to show that you had better results adding bortezomib to melphalan dex compared to melphalan dex alone. Of course, there was a little bit increase of neurotoxicity with bortezomib, but this trial was started some years ago, and there was a twice weekly schema regimen, and probably once a week injection of bortezomib. Bortezomib will give less neurotoxicity. So, in conclusion, this triplet combination to treat AL amyloidosis may be a new standard of treatment. So adding a proteasome inhibitor, bortezomib, to melphalan and dex. So these results are very encouraging, targeting not only the plasma cells but also the amyloidosis. Maybe I can show you just 3 slides summarizing the 3 clinical trials that have been presented during this ASH meeting. Can I see the other? Yeah, I will show you. Yeah, you can see the three trials I mentioned. So this is the EMN/OVEN trial. So the European trial that I mentioned. So the induction phase was VCD, 4 cycles, and then you randomize no transplant versus a single or a double autologous stem cell transplantation. So this is what I mentioned. So single is better than no transplant up front, and tandem may also be beneficial. And the maintenance phase has also been tested in this, the consolidation and maintenance. No, the consolidation has been tested. The other trial is the CTN network, the transplant network, American Transplant Network, for patients less than 71 years old. Induction, there were actually all kinds of induction regimen, single auto transplant, and then the 4 arms that I mentioned, no consolidation, 4 VRD or RVD, and a second auto transplant in tandem. And for all of them, lenalidomide until progression as a maintenance treatment, and no benefit of any kind of consolidation in this trial, as I mentioned. And finally, this is the English one, the Myeloma 11 trial, an induction with CTD or CRD. C is for cyclophosphamide, thalidomide, dexamethasone, or cyclophosphamide, Revlimid, dexamethasone. And it's a little bit confusing. I skipped the question of improving response before transplant. and then they got a transplant, or if they were unfit, no transplant. And the question that the trial that I mentioned, presented by Garrett Morgan, was the maintenance, no maintenance versus lenalidomide maintenance for both patient subpopulation, the transplant ones and the non-transplant patients. And in both cases, lenalidomide maintenance is beneficial. Thank you.
Okay, thank you very much, Dr. Garderet. I think it has been a very comprehensive overview of everything that came out of us, which has been a lot of things, and I think you have been very clear. So if you agree, I will open now the questions session. Some of you have already sent me some of your questions by writing. Remember, if you want to do your questions live using your microphone, you just have to press the raise hand button and I will unmute your microphone. So the first question that we have received says, you mentioned that nelfinavir, NIGHT treatment, is showing good results in myeloma refractory to bortezomib. Could this drug work as well in myeloma refractory with other proteasome inhibitors such as carfilzomib?
Okay. I'm sorry. I've just been told that the power in my hospital will maybe cut off in a few seconds. I'm really sorry. So as long as it's working, I will keep answering you. I'm very sorry. There are constrictions in the hospital. So the trial tested this HIV drug only in combination with Velcade Dex. So I cannot answer if it's also efficacious in combination with carfilzomib.
Okay, that's good. So let's go for the other question, as long as you still have power there in the hospital. So
yeah, I'm sorry. It's unexpected, but I'm just someone just opened my door and told me so.
Okay. I hope these are not budget cuts. Well, so the question says, I have heard that one of the new promising drugs in myeloma is venetoclax. What is the efficacy of this drug, and do you think it will become a key drug in myeloma treatment?
A key drug, I'm not sure. It is especially efficacious, as I said, for patients, so subset of patients who have a translocation 11-14, and this is about 10% of the patient, or even less. So it's difficult to say. As you know, all the new drugs are tested for all of them at the beginning in very, I would say, heavily pretreated patients. So the results are very encouraging in these very heavily pretreated patients. So therefore, you might expect that using this drug much earlier in the course of the disease, and also in combination as it is currently tested. Indeed, it may be an important drug, a major drug. I don't know. We will see. We need the trials.
Okay, thanks for that answer. The next question is, comparing the results of Polus and Castor, are they both, in your opinion, mutually exclusive? And which, in your opinion, will be the main factor for a physician to choose between Velcade or Revlimid to treat their patients?
So that's a good question. There will not be, all the patients will get it at some point. So it's not either VD plus DARA or RD plus DARA. It depends on what treatment the patient received previously. One must say that actually Pollux study is extremely successful because also most of the patients were lenalidomide naive They never receive lenalidomide. Therefore, of course, when you give them lenalidomide plus dex for the first time, and on top of it you're adding daratumumab, you get excellent results. But this is not a small subset of relapse patients. If you have never had lenalidomide, then yes, of course you will go for Lendex plus Dara. Most of the patients will already have received lenalidomide dex. So then why not Velcade dex? But you may say the same, use the same argument with Velcade dex. It depends on what the patient received before, what was the response with Revlimid dex or Velcade dex, and what was the toxicity. You see, so then once you know these three parameters, you can better choose if you go to Rev dex plus Dara or Velcade dex plus Dara.
Okay, thanks. We still have 4 more questions. Let's see, we have time for them. So the next question says, now that MRD assessment has been included in Polus and Castor, are we closer to have regulators such as the European Medicines Agency to take it into account as a valid surrogate endpoint in the approval process of new myeloma drugs and combinations?
That I don't know, but for sure in the new trials it has become, if not the primary endpoint, at least a secondary endpoint. Will it replace, will it be a real surrogate marker for PFS and OS? That may indeed be the case. We need more clinical trials to confirm this.
Okay, thanks for the answer. Next question is, what is your opinion on the update of the first trial presented by Dr. Facon? Would you be more inclined to go Lendex continuous or Lendex for 18 months?
So that is definitely a good point. Sorry. The problem is that as you know, there is no OS overall survival advantage, and therefore that brings us back to what treatment will you use at relapse. So if you keep this in mind, you may be more inclined to give a fixed treatment, such as Lendex 18 months. Because for sure, if you give Lendex continuously, when patient relapse on treatment on lenalidomide, then there's no question, you can't use a lenalidomide-based relapse treatment, and most of them nowadays are lenalidomide. Most relapse treatment are lenalidomide-based treatment at relapse. And on the opposite, if you have a fixed treatment, you have 18 months, let's say, and if 6 months later you relapse, for example, you feel very comfortable to start again lenalidomide dex. So I don't have a clear answer. It depends also on the patient population. If it's high risk, the patient response. So there are many parameters to decide if you will give it continuously or fixed time.
Okay, we have 2 more questions. The next one said it is becoming more and more frequent, the usage of combination of 2 and 3 drugs. Doesn't that increase the side effects of the treatment?
So the question is, do you increase the toxicity when you use a triplet versus a doublet?
Yeah, that's it.
That's it. Yes, that is definitely a good point. The more drugs you combine, the more toxicity you may experience. So there is a trade-off, between the toxicity and efficacy. There's no question that 3 drugs is most of the time, if not all the time, better than 2 drugs. But it's with the price of a higher toxicity.
Okay, so the last question, which is related with AL amyloidosis, and it says, you mentioned NEOT-001, which is aiming to become a specific drug for treating AL amyloidosis patients. However, infradiagnosis is still an issue in this disease. Will the efficacy of this drug might be reduced due to this cause?
Sorry, I didn't get it. Can you repeat the question?
Yeah, it is. You mentioned NEOT-001, which is aiming to become a specific drug for treating AL amyloidosis patients.
Yes.
But however, infradiagnosis is still an
Okay.
issue in this disease. So will the efficacy of NEOT-001 will be affected by this cause?
So the question is for fragile, unfit patients, right?
Or patients who are diagnosed late because of...
Well, the drug has almost, apparently no toxicity. It's first of all, we do have a lot of experience with monoclonal antibodies. It's usually, as it is with daratumumab and rituximab, very well tolerated, and this is the same, apparently, in these preliminary results, the case with NEOD. So this is not a real issue. If you're unfit, if you have a long history of AL amyloidosis, that this is not an issue. You will always be able to get it.
Oh, okay. So that was the last question, and before the power comes off, I would like to do the farewell, and I really think that it has been a very fruitful session for all of us. And Doctor, you, as I said before, you made a great overview of all that came out from us in myeloma and also in AL amyloidosis. So on behalf of MP, I would really like to thank you again for sharing your valuable time with us today. And
You're welcome.
thank you.
It was my pleasure.
Okay, and I would also like to thank all of our attendees for joining us today. And just before we finish, I would like to remember that the webinar has been fully recorded and it will be uploaded shortly to our YouTube channel and our website, which is www.mpeurope.org. So remember also to visit the member section in our website to stay in touch with your local myeloma group in case you haven't done it yet. And don't forget to follow us in Facebook and Twitter. We hope you have enjoyed today's session, and we are looking forward to meet you soon in our next webinar. And thank you very much for trusting Myeloma Patients Europe. I wish you all a very good evening. Thank you, Doctor. Bye-bye.
You're welcome. Bye-bye.